Good afternoon and welcome to today's wonderful evening with Dr. Murali Bharadwaz. Every day we meet, every day we have a live discussion of 22,000 PYQs. And in another 200 hours, we finish the revision of the all 22,000 PYQs. And you are ready to be the champion for the next NEETPG exam. Good to see two online classmates. Good. So, doctor, how is the portal being formed? So, you need to know that there is a superior mesenteric vein, and here you are having the splenic vein, and together are merging to form the portal vein, and the portal vein in turn will divide into the right and left branches. So superior mesenteric vein, the splenic vein, and there are two gastric veins which you need to remember, which are merging to form the portal vein, is what you have to basically remember. So now, doctor, Kellogg's triangle, once more a repetition. Cystic artery plus right hepatic artery, the lymph node of the lung, they are the parts of the Kellogg's triangle, is what you have to remember. Now, a lot of times in the NEETPG, they ask about the various anatomical landmarks, which you need to be very, very good with. So, if you look at the transpyloric plane, so the stomach is having the pylorus, right? So the transpyloric plane, if you take, what are all the structures that are there at the transpyloric plane? The pylorus of the stomach, the neck of the pancreas, the fundus of the gallbladder, and the duodenojejunal flexure, where the duodenum is merging with the jejunum. So duodenojejunal flexure, and the end of the spinal cord of the adult, which happens at the L1 level. Typically, transpyloric plane corresponds to L1 level, is what you need to remember. Then what is subcostal plane? Subcostal plane is at the level of the L3, and it is the origin for the inferior mesenteric artery, is what you need to remember. Then supracrystal plane. It is at the L4 level, and that is the point where there is a bifurcation of the aorta. So we need to know what are all the structures that are at the level of the transpyloric plane, and transpyloric plane is at the level of the L1. So fundus of the gallbladder, hilum of the kidneys, pylorus of the stomach, they're all at the level of the transpyloric plane. Now, doctor, what is the pancreas blood supply? Pancreas, the essence of our life. So what is the most common cause of the pancreatitis, doctor? It is the alcoholism, the most common cause. And also gallstones can lead to the slipping of the gallstone, and that can lead to the ultimate development of the pancreatitis. That's another possibility. So pancreatitis is of two kinds. Remember, pancreatitis, if you take, is divided into two kinds. One is called acute pancreatitis, other is called chronic pancreatitis. So alcohol and gallstones, they are the two important causes in acute pancreatitis. And chronic pancreatitis can be hereditary, right? Is what you need to remember. So how do you identify whether it is acute or chronic pancreatitis? If you take the plain radiograph, the pancreas typically will show the presence of calcifications. If you are able to see the calcifications in the pancreas on a plain radiograph, that is an indicator of the chronic pancreatitis is what you have to remember. Now, doctor, so you should know what is the blood supply of the pancreas. A lot of you are going to become surgical gastroenterologists. Day in, day out, you will be doing the Whipple surgery, where the pancreas is being resected. So, gastroduodenal artery, superior mesenteric artery, and the pancreatic branch of the splenic artery. So, you should know, if you look at this entire pancreas, right? The spleen is closer to the tail of the pancreas, right, doctor? So here you have the splenic artery, you have the pancreatic branches of the splenic artery, the greater pancreatic artery, the dorsal pancreatic artery, inferior pancreatic artery. So these are the various structures which you need to remember. Similarly, superior pancreatico-duodenal artery, anterior superior pancreatico-duodenal artery, and inferior pancreatico-duodenal artery, the various parts in the blood supply of the pancreas is one of the favorite area of the examiners. So summarize, doctor: gastroduodenal artery, superior mesenteric artery, pancreatic branch of the splenic artery, they are the ones which are supplying the blood to the pancreatic artery. Very good to see, in spite of wonderful afternoon. So I'm now broadcasting from Hyderabad, right? So now the digital TV or panel is the modern way by which we have the same experience like a face-to-face class. All right. So today only, if you have not subscribed in our program, we have a program called 999 rupees program. We have a program called 999 rupees program. The cheapest NEETPG coaching ever available across world. Whether you are preparing for NEETPG or INICET or FMGE exam. So in this we offer two things. One is we offer a video library, right? We have a score learning app, Android, iOS, and also we have a website called onlinemmbbs.com. So on that you get around 300 hours of video. All right. And this covers 19 subjects. And these videos are not very long. They are only 5-minute short videos. So totally 3,600 short videos. These are all available for 6 months for you to access. In fact, we can extend it up to 1 year, no problem. In addition to this, there are 22,000 PYQs. So these are converted into single liners, topic classified and made available to you, right, doc? And these are discussed in over a period of 200 hours in a daily live class to motivate you to do the revision. So these videos are removed from the YouTube after the broadcast and made available in the video library. So this entire program is just 999 rupees, cheaper than going to a movie with a girlfriend, right? Only one girlfriend with a nice coffee. More cheaper than that, we made the entire NEETPG coaching. So today only tell your juniors and everybody to subscribe for our 999 rupees program for the NEETPG preparation. I'll be there with you for 6 months until you get the seat and hold your hand to become the winner. So to subscribe to this program, right? To subscribe to this program, today only call our helpline 900-868-356. I left the number below this video. Please like this video, share this video to all your friends in all social media, Let us revolutionize and make the preparation for the NEETPG, FMGE and INICET affordable for everybody for just 999 rupees, 1 year subscription. So, doctor, continuing our journey, what are the branches of the external iliac artery? External iliac artery has femoral artery, deep circumflex, inferior epigastric artery. They're all the branches of the external iliac artery. Iliac artery. Right? So, facial nerve. The next story is facial nerve. So, how to subscribe to the program? So, please call, our helpline numbers are there. They will help you how to subscribe to test series, our video library, our notes, everything. Now, doctor, facial nerve. Facial nerve passes through stylomastoid foramen. And after passing to the stylomastoid foramen, it gets divided into 5 branches: temporal, mandibular, zygomatic, buccal, and cervical. Right? It's called Pessancerinus, is what you have to remember. So if you look at the digastric, the posterior belly of digastric is supplied by the facial nerve. Right? And parotid gland is in very close relationship to the facial nerve. Now, coming to the superior orbital fissure, what are the contents of superior orbital fissure, doctor? Inferior ophthalmic vein, lacrimal nerve, nasociliary nerve. They're all the contents of the superior orbital fissure. In my yesterday's class, I discussed about superior orbital fissure, inferior orbital fissure. What are the contents of each of these fissures? You like it, you don't like it, you need to mug it. Right? Similarly, greater sciatic foramen, lesser sciatic foramen. What are the contents? Every time you go to the NEETPG, FMGE or INICET, these are the standard questions which you need to remember. Right. Now, doctor, superior orbital fissure. What does it contain? It contains abducens, trochlear, oculomotor nerve. They all pass through the superior orbital fissure. Now, where is the anterior fontanelle is formed? You should know the frontal bones, coronal suture, sagittal suture. Between them, you are having the anterior fontanelle. So, you can easily guess, what is this frontal bone? What is this parietal bone? And here you are having the anterior fontanelle, and this is called the coronal suture. Coronal suture. There is another way you can see this is the coronal suture, the metopic suture, this is the sagittal suture, and here you have the posterior fontanelle. Another way, in a bigger version, this is the anterior fontanelle, the coronal suture, metopic suture, sagittal suture, and in the posterior aspect, you have the lambdoid suture. Lambdoid suture. Now, what are the various bones which are called pneumatic bones? Maxilla, frontal, ethmoidal, they carry the paranasal sinuses. That's the reason they are called the pneumatic bones. Apex of the orbit. What do you have? Superior oblique, superior rectus, medial rectus, all of them take a common origin from the orbit's apex. So the common tendinous ring, the orbit's medial wall, lateral wall, superior wall, inferior wall, all these things we discussed in the last class. But orbit as such is a favorite question of the topic of the examiner. Now, coming to the nasal septum. How is the nasal septum is formed? We have a septal cartilage, crest of maxilla, perpendicular plate of ethmoid. They are all the ones which form the nasal septum. So let us have a bigger picture. You know, this is the frontal sinus. This is the perpendicular plate of the ethmoid. This is the quadrangular plate of the ethmoid. Here you have the vomer. पीछे क्या है? Vomer के पीछे क्या है? Sphenoid sinus है. And what is this, doctor? This is the maxillary crest, otherwise called the typically you have the palate, hard palate, the maxillary crest. So you should know what constitute the nasal septum is the favorite question of the examiner, right? So is sphenoid bone a pneumatic bone, sir? Beautiful question. You have a sphenoid sinus. The moment you have a paranasal sinus, it is a pneumatic bone. As simple as that. Any calvarial bone which is containing the paranasal sinus is a pneumatic bone. Right, doctor? Now, what are the various muscles that constitute the perineal body? Perineal body. So the external sphincter, iliococcygeus, superficial transverse perineae, they all constitute the perineal body. Perineal body. Similarly, levator, bulbospongiosus, deep transverse perineal muscles, they're all the perineal body. So you should know perineal body, pelvic diaphragm, what is the composition of them, which muscles form each of them, what is superficial perineal pouch, deep perineal pouch, and each of them, what are the boundaries, what are the contents, everything you should know. So what are the 4 things you are going to quickly go back and do a quick review in your anatomy book or the notes, whichever? Perineal body, superficial perineal pouch, deep perineal pouch, and the pelvic diaphragm. So pelvic diaphragm has iliococcygeus, ischiococcygeus, pubococcygeus, everything is coccygeus. It's a hot dog. Iliococcygeus, ischiococcygeus, and pubococcygeus constitute the pelvic diaphragm. Now let us look at the things in action. So this is the penis, right, doc? So this is the penis. Then you have the ischiopubic ramus. Here you have the perineal membrane, and this is called ischial tuberosity. Then this is called the perineal body. And what is this called, doctor? Puborectalis, pubococcygeus, iliococcygeus, all these 3 muscles are located here. You're able to see, right? They constitute the pelvic diaphragm. And here you are having the anus, and the obturator internus muscle is over here. So this is the typical structure that you need to remember. So fundamentally, what is orgasm? Orgasm is nothing but, in case of the women, the clitoral stimulation lead to contraction of the various pelvic muscles, which is defined as orgasm. So there is also a condition called anorgasmic disorder, where some women fail to achieve orgasm throughout their life. But it's not a very big myth or hoax. Orgasm is a clitoral stimulation leading to the various pelvic diaphragm muscles, everything going into contraction. So, doctor, one more look for you. You can see this is the pubic symphysis. These are the perirectal fibers, and you can see the obturator internus, obturator canal. Then this is the coccygeus, and we have the anococcygeal membrane. You can see the coccyx and the sacrum. And here you have the levator ani group of muscles. So what does levator ani contain? Puborectalis, pubococcygeus, iliococcygeus together is called the levator ani group of muscles are typically located over here. So the orientation towards the pelvic muscles is one of the favorite questions of the examiner, which you need to be very sure about, right? Very good. So, doctor, branchial pouch. So you should know what are the various branchial pouch derivatives, branchial arch derivatives, etc. So superior parathyroid, inferior parathyroid and thymus, all of them are formed from the branchial pouch. Now what are the parts of the gut which are called the midgut, hindgut and foregut? So appendix, jejunum, ascending colon, they're all the part of the midgut, right? So starting from second part of the duodenum where the ampulla of water enters into it, from there the midgut will begin, is the point of importance. Now, which ribs are called true ribs? Fifth, sixth, seventh ribs are called the true ribs, true ribs. So, what are the various accessory respiratory muscles which will function when the person is severely dyspneic beyond the regular intercostal muscles? Sternocleidomastoid, scalene, erector spinae. These are all called the accessory muscles of respiration. Now, you know, voice of America. Vena cava opening, O for esophageal opening, A for aortic opening, T8, T10, T12, the three levels at which we see the diaphragmatic openings every time, the favorite question. Now, what are the structures which are in relation to the left kidney and the right kidney? Anti-relations, posterior relations is one of the favorite areas of the examiner, right? So, Charu Bala is asking, sir, please discuss the MCQs. These are all PYQs only, the MCQs only. But instead of wasting your time, they are being converted into single liners and made available to you. Solving 22,000 single liners, which are the very, very high yield facts, is more easier in 200 hours than solving every MCQ. Understand? So this 22,000 PYQs as single liners, once we do revision in 200 hours, you know what examiner exactly wants. All right, doctor? Now, left kidney relations, what are they? Jejunum, splenic flexure, left suprarenal gland. They're all the anterior relationships of the left kidney. Left kidney is what you need to remember. Now, if you look at the rectum, what are the relationships of the rectum is another favorite area of the examiner. The sacral vertebrae, the superior rectal artery, middle rectal artery, they all pass posterior to the rectum. The sacral vertebrae, superior rectal artery, middle rectal artery, they all pass posterior to the rectum is what you need to understand. Now, if you look at the abdominal aorta, what are the branches of the abdominal aorta? Celiac trunk, superior mesenteric artery, inferior mesenteric artery, they're all the various ventral branches of the abdominal aorta. So you should know renal artery, celiac artery, mesenteric arteries, all these gonadal artery, how do they originate? Which are anterior, which are lateral, which are posterior, arising from the tube, which is called as descending aorta. So out of that, the mesenteric arteries and celiac trunk are typically arising anteriorly from the aorta. They are ventral branches of the aorta. Now, if you want to know if the facial nerve, glossopharyngeal nerve are intact, what tests will you do? So, basically, the position of the uvula, the symmetry of the palate, and the deviation of the tongue, they are the ones which will help you to identify how is the glossopharyngeal nerve, the facial nerve, hypoglossal nerve, etc., etc. Now, coming to the taste sensation, you all know fifth cranial nerve, that is trigeminal through lingual branch. Seventh, with the chorda tympani carrying from the anterior 2/3 of the tongue. Ninth, glossopharyngeal carrying from the posterior 1/3 of the tongue. They carry the taste sensation from the tongue. So taste sensation of the tongue is decided by the 5th, 7th and 9th, the 3 important cranial nerves. Now coming to the anatomical level once more. Pharynx ends, esophagus begins, larynx ends at the level of the C6. At the level of the C6. Now, doc, what are the various ligaments in the temporomandibular joint? Temporomandibular ligaments, sphenomandibular ligaments, stylomandibular ligaments, they are the 3 ligaments in the temporomandibular joint. Now, until what level do you call it as lower motor neuron and what level you call it as upper motor neuron is a favorite area of the examiner. Now, let us master this point. In the brain, there is an area which is pre-sulcus, which is called as motor area. Here you have pyramidal cells of beds. What do they call, doctor? Pyramidal cells of beds. From here arise our motor pathway, which is hence called pyramidal tract. So it descends down and it passes and consolidates in an area which is called internal capsule. Surrounding that you have islands of grey matter which are called as basal ganglia. Okay? From there it will descend down ipsilaterally, that means right is going down on the right side. Then once it reaches it crosses midbrain, pons and medulla. Once it reaches let us say this is the midline, lower part of the medulla, it undergoes decussation to the opposite side. Right became left. Then on the left side, you are having the spinal cord at various levels. So it reached on to the opposite side, and here it will be landing on the anterior horn cell. From the anterior horn cell starts our peripheral nerve. And this peripheral nerve will travel until it reaches the neuromuscular junction, right? So in the neuromuscular junction, what do you have? Presynaptic membrane and postsynaptic membrane. Here you have the sodium channels, which will cause the release of voltage-gated sodium channels, which will cause the release of the acetylcholine, which will then go and bind with the postsynaptic membrane, and from there action potential is generated and muscle undergoes contraction. So in this entire journey, the corticospinal tract until the point of anterior horn cell is called upper motor neuron. Then anterior horn cells, peripheral nerve, until the presynaptic membrane, it is called lower motor neuron. Whereas the postsynaptic membrane, which is affected in myasthenia gravis, or the muscle, which is affected in myopathies, they are not the part of the LMN. That's the reason whenever this upper motor neuron is affected, how will be the jerks? Deep tendon reflexes. Deep tendon reflexes are all exaggerated. Barabar? Whereas the lower motor neuron is affected. Whenever this lower motor neuron is affected, deep tendon reflexes become diminished. Right? So what is that condition where presynaptic membrane is affected, called as Eaton-Lambert syndrome? Eaton-Lambert syndrome. Even Eaton-Lambert also is an example of a lower motor neuron involvement because it is involving the presynaptic membrane. That's the reason even in Eaton-Lambert also deep tendon reflexes are diminished. Whereas postsynaptic membrane, where myasthenia gravis is there or the muscle is involved, that is in myopathies, deep tendon reflexes are normal. That is exactly the point examiner will test you. What is the difference between Eaton-Lambert and myasthenia gravis? Myasthenia gravis may deep tendon reflexes are normal. Myasthenia gravis may deep tendon reflexes are normal because it is involving postsynaptic membrane. Or myopathies also deep tendon reflexes are normal. Whereas Eaton-Lambert deep tendon reflexes are diminished. Peripheral neuropathies deep tendon reflexes are diminished. Anderson, as in the poliomyelitis, deep tendon reflexes are diminished because it is still the part of the lower motor neuron. Whereas whenever there is any stroke in the brain, whenever there is any bleed in the internal capsule, whenever there is any damage to the corticospinal tract, then the deep tendon reflexes are typically elevated, is what you have to ultimately remember. Good, doctor. Now, once you have this clarity, everything else is easy. So what are basal ganglia, doc? Caudate, lenticular, globus pallidus. They are all called the basal ganglia. Okay. Now, that completes almost the anatomy. How many? 421 MCQs in the past 10 years of anatomy from the FMGE exam. So once you solve almost 1000 PYQs are there in anatomy in NEETPG. Another 400 PYQs in INICET. So once you solve this 400 plus 400 plus 1000, almost all 1800 PYQs you have solved as single liners. Now you know what examiner exactly looks forward for you to do the revision for the tomorrow's NEETPG or tomorrow's INICET exam or tomorrow's FMGE exam. So that those 5 beautiful marks you are going to conquer in the tomorrow's exam. So doctor, let's go to the anesthesia. Starting with 2021 FMGE paper, oxygen cylinder is being provided and asked to you to identify. So typically oxygen cylinder will have a black trunk and a white top. So you should basically remember. Now, whenever there is a negative pressure, right, the ventilatory pressure, that lead to pulmonary edema, typically after extubation. You have intubated, patient recovered, and you have extubated. That time that create a negative pressure, and that lead to pulmonary edema, which can lead to the development of the desaturation after the extubation. Now, all the remaining anesthesia is just a quiz. Best agent in cardiac patients, which inhalational agent? Isoflurane. What are the 2 intravenous agents that you know? Propofol, thiopentone, and etomidate are the hypnotic agents which are used to give the anesthesia. Now, for how long before a laparoscopic surgery you need to keep the patient nil orally? For about 8 to 12 hours. So once more, every exam you go, oxygen cylinder color coding is a favorite question. So how do you manage COPD? Any decrease in FiO2, if a COPD patient on oxygen therapy What does it mean? It means to say he is going into hypoventilation. That's the reason always in COPD patients there is something called permissive hypercapnia. So what is the meaning of that? In a patient who has got COPD, if you happen to give, if they are having a little higher side of the PCO2, it is okay, because this is driving the patient to have ventilation. If you are giving high flow oxygen insufflation to this patient, he will go into ventilatory failure because there is no more drive to ventilate. That's the reason always, what is the rule in COPD patients? Keep the oxygen flow not more than 2 liters per minute. That is, low flow oxygen inhalation is the one which is being advised. Now coming to the epidural anesthesia. Your needle is passing. What are all the various layers through which it is passing? Supraspinous ligament, interspinous ligament, and ligamentum flavum. So, doctor, this is a very easy illustration to understand. What you are seeing here is spinal cord. Then you have this black colored one is dura mater. So here you have the interspinous ligament. Between the two spines, you are having the interspinous ligament. All right. Then you are having a supraspinous ligament. There is a ligamentum flavum. Ligamentum flavum is what you can see. And there is a subarachnoid space, the one which is immediately abutting, that black line which is immediately abutting the spinal cord is the subarachnoid space. And then there is something called, above the level of the dura, epidural space. So to reach out to this epidural space, you need to pass through interspinous ligament, supraspinous ligament, and the ligamentum flavum. The needle need to pass to reach the epidural space is the point of interest. Now, how do local anesthetics function? Local anesthetics act by blocking the sodium channels. Sodium channels. So what is the size of the cannula that you use? If you want a maximum rapid fluid flow, IV fluid flow, we use a 14 gauge cannula. It will allow for maximum rapid fluid. So you should know, doctor, the various gauzes. One of the favorite area in the entire anesthesia that you need to remember for the tomorrow's exam. All right. So 14 gauze we use for rapid infusion surgery. And how many milliliters will pass per minute? 240 ml will pass per minute. Then 16 gauze, rapid infusion during surgery, 180 ml per minute. 18 gauze, for the blood transfusion we use 18 gauze and 90 ml per minute can pass. 20 gauze we give for IV fluids and passing medicines intravenously, and the flow will be 60 ml per minute. 22 gauze, typically 36 ml per minute, and IV fluids into small veins is administered through 22 gauze. 24 gauze, 20 ml per minute is the flow rate, and fragile veins, especially pediatrics. 26 gauze, typically 13 ml per minute is the flow rate, and it is used in the neonates. This particular slide, you have to mug it by heart for the tomorrow's exam, doctor. Yes. Now, if you look at the color coding, you should also know the color coding of the various gauzes of needles, 24, 22, 20, 16, 14, 24, etc., etc. So, always this is a very important point you need to know. 14 gauze, 16 gauze are both called the larger catheters and are more difficult for you to insert. And they may cause greater discomfort, more inflammation. They are used for larger veins. 14 gauge has highest flow rate and it is used for the IV volume resuscitation. Right? Then 18 gauge and 20 gauge, they are the ones which are used for the standard intravenous therapy, routine blood transfusion and albumin infusion. 22 gauge is for the basic IV therapy, pediatric patients or very elderly people who have very fragile veins. 24 and 26 gauge is for the neonates, no rapid flow, and also whenever you are giving a bridge therapy for rehydration. And always the rule is choose the smallest gauge as much as possible whenever you are doing the infusion is what you have to remember. Pro-seal LMA. So what is, it is being given as a image-based question. So you should know there are certain airways which are called the supraglottic airways. Supraglottic airways. That means you are passing it and it is staying above the level of the vocal cords. Intubation means you are passing through the vocal cords into the trachea. Endotracheal intubation means. So this is above the level of the glottis. It is providing a protection from the fluids in the gut from going into the respiratory tract. So the supraglottic airways, they are being designed to provide a better seal of the airway and relatively safer is what you need to remember. So if you look at this LMA, which is called Pro-seal LMA, it has a pilot balloon, then 15 mm airway connector. There is something called a bite block, drain tube, reinforced airway, softer cuff, strap to introduce, deeper bowl, drain tube tip. So they are the components of the Pro-seal LMA. Pro-seal LMA. So once more, tomorrow's exam they will give this. You should know there is a 15 mm connector, drain tube which accepts the 18 French rail tube. There is a bite block, inflation line, pilot balloon, finger strap, airway tubes, distal aperture, inflatable cuff and distal aperture of the tube. Right, doc? So this is the typical way. So where you can be able to hold it, the LMA, and then you are negotiating it into the respiratory tract and you are reaching to the supraglottic area. You will place it in place and remove the introducer. So this is how Pro-seal LMA is being operated. Now what is meant by Tauhe's needle? You should know how to recognize Tauhe's needle for doing the lumbar puncture, right? So this is the typical Tauhe's needle, right? And these are all this is 16 gauge. And here you are having markings at, they are called centimeter markings you are having, okay? So this is how into the epidural space you will be introducing the Tauhe's needle is what you have to remember. So how do you give daycare anesthesia, doctor? Propofol, which is called milk of amnesia because it is white in color. And it is used in all the intravenous sedation protocols in the ICUs. So propofol is preferred for the daycare anesthesia also, And also it is used whenever you ventilate a patient, connected him to ventilator, he is fighting against the ventilator, you want to sedate him without depressing his cardiovascular responses. Then we will be using propofol is what you need to understand. Now, all the contraindications of thiopentone. Acute intermittent porphyria is a contraindication for thiopentone, is a favorite area. Ketamine, everything will rise with ketamine. Blood pressure rises, intracranial tension rises, intraocular tension rises. And ketamine will cause hallucinations. They are called emergence delirium. When the patient is recovering from the ketamine, he develops emergence delirium. He develops hallucinations. Is a favorite PYQ. Then, whenever the patient is having a lot of cardiovascular risk, hysterectomy is typically done between 50 to 60 lot of times. But if they develop cardiovascular risk factors, you need to be careful and avoid laparoscopic hysterectomy. Rather, you need to do conventional hysterectomy. Then, endotracheal tube, instead of passing into the trachea, if you happen to pass into the esophagus, then how do you identify? The CO2 exhalation is the best way to know whether you have placed the endotracheal tube in trachea or in esophagus is very, very important. So, dentists, actually anesthesia was first demonstrated by W.T. Morton. Morton was a dentist. Dentists are actually credited for introducing the anesthesia. So, dental surgery uses field block, nerve block and infiltration anesthesia. Now, whenever there are hypotensive episodes during the spinal anesthesia, whenever there are hypotensive episodes in the spinal anesthesia, what do you use? We use ephedrine. Whenever hypotensive episodes are there when you are doing spinal anesthesia. What is the shortest acting of all the local anesthetics, doc? Lidocaine is the shortest acting local anesthetic agent. So what is a nasal cannula? Nasal cannula is a low flow variable performance device to pass the oxygen. So accordingly, if you look at the equipment which is used to oxygenate a patient, they are being divided into low flow and high flow. So any mechanical ventilation, hyperbaric oxygen chambers, high flow nasal cannula, they are all high flow. Whereas Venturi mask, nasal catheter, face mask, low flow nasal cannula, they are all the examples of the low flow oxygen devices. So this is an example of what you are able to see, a one-way flap valve containing nasal airway, right? Then this is, it may have a non-breather mask which will allow one-way gas flow through the flap valve. So accordingly, you have a non-breather mask or a simple face mask. They are the two types. Okay. So what are the various parts? You have a CPAP mask or a simple mask, nasal mask. And similarly, whenever you are passing a positive end expiratory pressure to ventilate the patient non-invasively, then you can use, this is a oxygen tubing inflation valve, positive expiratory pressure valve. All right. So CPAP is also called NIV, non-invasive ventilation. Whenever the patient, you don't want to intubate and connect him to the ventilator is what you should remember. So, which anesthetic lead to the hepatitis doctor on repeated administration? Halothane is what we need to remember. Then what gas is used to create the pneumoperitoneum during the laparoscopic surgery? Carbon dioxide is the one which is used. And pre-anesthetic checkup how do you know whether the patient has an adequate airway? Is it easy to intubate or not? It is the Mallampatti scoring. Mallampatti scoring. How do you do that? Class 1 means complete visualization of the soft belly. Complete visualization. Whereas complete visualization of the uvula is class 2. Visualization of only the base of uvula is class 3. And soft palate is not visible at all, then that is called class 4. So this is a favorite image-based question. Examiner will expect you to know which Mallampatti classification does it basically belong to. All right, doc. Now, how do you know endotracheal tube position? If you look for and check for the presence of the oxygen in the exhaled air, you know whether it is there in the trachea, the tube, or it is there in the esophagus. All right. So this is the typical end tidal carbon dioxide levels are calculated. So this is how you have the graph which is called capnography. And how much is the end tidal CO2, doc? 35 to 45 mm mercury. Then you call that it is inside the trachea. Then what is capnometry? Capnometry means if it is the carbon dioxide which is coming out of the endotracheal tube, then it will change the color of the dye. The dye is typically purple when exposed to low CO2, and it will be yellow if it is exposed to higher CO2 levels. Based on that, you know whether it is in tube or not. So in this context, you need to know the various capnographic patterns which examiner will ask in the tomorrow's exam. Right? Now, normal capnography if you take, how does it look like? In normal capnography, there is a normal end tidal CO2, normal waveform amplitude, normal respiratory rate, and the baseline, this is the baseline. The end tidal CO2 will be typically 40. Clear? Now, if the patient is hyperventilating, the end tidal CO2 will decrease, the waveform amplitude will decrease, the respiratory rate will decrease, and the EtCO2 will decline. If you look from here, it is lower than the baseline. Clear? Now, if he is a bradypneic hypoventilation, the respiratory rate decreases. You can be able to very clearly see. Similarly, how it looks like in hypoapneic respiration. Similarly, if he is hypoventilation and apnea is there, how does it look like? The EtCO2, end tidal CO2 can become 0 if it is a hypoapneic, hypoventilation and apnea. If you are doing an ineffective chest compression, EtCO2 will be less than 10 mm during the CPR. Similarly, if you are doing an effective chest compression, it will be 10 mm. EtCO2 will be more than 10 mm during the CPR if your CPR is effective. So similarly, sudden loss of the waveform. So this is the typical waveform. Sudden loss of the waveform if it is there, then think about dopes. D for displacement of endotracheal tube, O for obstruction, P for pneumothorax, E for equipment failure or a kink. Dopes is a mnemonic to remember if there is any sudden loss of the waveform of the capnography. Then decreasing EtCO2, increasing EtCO2, shark fin pattern, this is called. This is called shark fin pattern. This is typically seen in asthma, COPD, bronchospasm. In that, what do you get? Like a fin of the shark. One of the favorite MCQ in the exam. Then if it is elevated from the baseline, that means there is an insufficient expiratory time. Okay. Then if there is any small dip, then it is called the Curare cleft. This is called Curare cleft. On the top, you can see the small dip, right? So that means the patient attempts to breathe when the paralysis is still partial. When the muscle relaxant that you have given is causing a partial paralysis, then you get the Curare dip in the capnographic pattern. So once more, Mallampati classification is for airway difficulty. And what is this device? Lot of times examiners will give you an image-based question. This is the device to introduce the carbon dioxide to insufflate the abdomen whenever you are doing a laparoscopic procedure to create the pneumoperitoneum. So, colloids, crystalloids. Which is the fluid of choice in surgery? Crystalloid is the fluid of the choice in surgery. Right, doc? Now, what are the drugs included in the advanced cardiac life support, ACLS? Adrenaline, amiodarone, soda bicarb. Adrenaline, amiodarone, and soda bicarb are the ones which are included. So, if you look at the adult advanced cardiac life support, once the patient is unresponsive, open the airway, do CPR at a ratio of 30:2, very important, right? Attach the defibrillator, assess the rhythm, check whether that guy is shockable. If he is shockable, that means there is V of pulseless VT, then give the first shock. How many joules do you deliver? 150 to 360 joules biphasic or 360 joules monophasic shock is being delivered. Then immediately resume the CPR at a ratio of 30:2 for 2 minutes is what you need to remember. Suppose if he is non-shockable, then you resume the CPR. That is a very, very important principle for the next 2 minutes. And once more see whether he becomes shockable or not. So what are the various reversible causes that lead to the cardiac arrest, doctor? Hypoxia, hypovolemia, hypokalemia, hypothermia, tension pneumothorax, tamponade, cardiac toxins, any coronary thrombus. Any of them are the reversible causes that lead to the cardiac arrest. So with this, we'll call it a day. Every day, रोज मिलेंगे, रोज पढ़ेंगे और एक दिन कामयाब होके दुनिया को बताएंगे भाई मेरा सीट, मेरा नंबर आ गया. So don't forget, today only subscribe into 999 rupees program, where 1 year coaching is being given just for 999 rupees. And you get 400 hours of video content subscription on the video library. And in addition, 200 hours of live interactive discussion covering 22,000 PYQs. The entire thing just for 999 per year subscription you buy today itself. Thank you so much for being part of the game, and we will meet once more tomorrow and finish some more 100 to 150 PYQs every day is a plan. Thank you, doctor.